Okay. All right. So we're going to test for a DRA, a diastasis rectus abdominis. Your DRA is when your rectus abdominis bellies, right? You have one on the left, you have one on the right. This is your six-pack abs that everybody tries to get. It's a split in them, okay? So when your patient or client lifts their head, what will happen is there'll be a separation between the belly on the left and the belly on the right. And so that's what we're going to test right now. We could test this with a real-time ultrasound machine, and that would be wonderful. We're going to use finger tips and finger pads right now, finger widths. There is a research study out there that shows using the testing procedure I'm about ready to use and comparing it to a real-time ultrasound, and it's consistent and it's valid as long as you have the same person testing your patient on every treatment. So I'm doing research right now on DRAs, and so I test this the same way every single time. You technically can test anywhere from inferior to the xiphoid process to just superior to the pubic bone. I, however, find that most of the DRAs, especially the larger ones, are pretty much around the belly button, around the umbilicus. So where we're going to test her DRA is this. I'm going to put my right ring finger in her belly button, the superior aspect of her belly button, and where my right index finger comes, that's going to be my first testing spot, is right there. Okay, so I'm going to test this, and then when I get to retest, you'll see I'll do the same procedure. So this is going to be my first position. I turn my fingers like this, and I put a little pressure into that. And then what she's going to do is she's going to raise her head, and then as she raises her head, I'm going to see how many fingers fit in between those rectus abdominis bellies. And for her, right now, she is a good, probably 3.5 right now. So I've got a roomy 3, if that makes sense. So I would give her a 3.5 for the split, but it's kind of shallow. And then she's going to put her head back down. So about 3.5 for my first one. And then for the umbilicus testing, I come down right at the umbilicus, middle finger's in it, the other fingers are beside it. I sink in and I say, go ahead and lift your head up for me. Yeah, she's going to be consistent on us. She's still a 3.5 split. So I've tried to put this finger in. I can get it about half in. So 3.5. So we got 3.5, 3.5. But again, not a lot of depth. So some of the DRAs have a depth to them. And as we do the treatments, that depth starts going away. So this is good that these are shallow. However, we would like it to be more together so that these muscle bellies can actually support her back, assist her in lifting, obviously assist with any pelvic functions as well, and support those organs as well. So our third spot is inferior to the umbilicus. You'll see me, I'll put my right index finger in the inferior aspect of the umbilicus. My other two fingers will just go straight down the linea alba. And where my right ring finger is at, that's going to be my third testing spot. Okay, just so I do it the same spot on each time that I test and retest her. So my fingers are here. I'm going to have her lift her head up for me. Lift up a little bit more so I can feel that. Yep. Yeah, so consistent. Okay, so she's like a 3.5 here as well. And so go ahead and put your head down. When she lifts her head up, the bellies kind of pop up, and so that's what I'm feeling for, is the split in between the muscles bellies popping up. So it's literally 3.5, 3.5, and 3.5, but they're all shallow. And so that's kind of where we're starting right now before this treatment. Our hypothesis with this treatment is that working the jejunum-ilium actually brings these muscle bellies together, okay? When we talk about the jejunum-ilium, we have 3 parts of the jejunum-ilium, or small intestines, if you will. One aspect is called the root. The root is where the parietal peritoneum, which is the balloon, it's kind of big, like a big water balloon that most of your organs fit in. It goes around and it thickens up on the back wall. It thickens up and it becomes the root of the jejunum-ilium. And it pretty much runs from DJ junction, or where the duodenum and the jejunum meet, all the way down to the ileocecal valve. where the cecum and the ilium kind of meet as well. Okay, so that's kind of where the root's going to be. We have an aspect that's superior. We have an aspect that's inferior. And it runs kind of like my fingers are right here. And it's just a thickened piece of parietal peritoneum. We find that if there's restrictions in this aspect of the jejunal ilium, or the mesentery, which is literally a sling that continues on and wraps around 21 feet of small intestine, or between loops of the small intestine, if there's any restrictions on that back wall, what typically happens is those restrictions kind of tighten up, and then they literally pull the parietal peritoneum lateral and posterior, and when they do that, they pull the fascia that's above it, which is kind of the transverse abdominis fascia. That gets pulled with it. The transverse abdominis gets pulled. Eventually, the rectus abdominis fascia and the rectus abdominis bellies gets pulled lateral and posterior. So what we're finding is when we release these restrictions in the thickened piece of parietal peritoneum, or the extension of the parietal peritoneum, which is called the mesentery, the restrictions release, and all of a sudden it's like it just springs back forward, and then everything kind of goes back together. It's taking us about 4 visits to close a DRA and for it to be stable. I don't know why, but it's literally 4 visits, and then whatever we get, that's what we get, and that's where we're at. Breastfeeding will, we have to treat people longer for breastfeeding because we work through the proprioceptors and mechanoreceptors. And so the breastfeeding makes the ligaments a little loosey-goosey. And so it's kind of like static on a line when you're talking to somebody. So we can do it. It's just going to take longer. And sometimes we have to kind of send them away until they're done breastfeeding. And then they come back, and then we can kind of close it up a little bit more. So our idea is if we can release this and we can get the rectus abdominis bellies back together more, now you can go and do all of your core strengthening when these guys are actually in the alignment that they're supposed to be in, and we're no longer at risk for like an umbilical hernia or something to that nature. So let me kind of show you what's going on with my demo here. Okay. So if we think of these kind of maroon aspects as the root of the jejunal ilium, the inferior aspect of the root of the jejunal ilium is inferior to the umbilicus. And then the superior aspect of the root is superior to the umbilicus. Again, our lateral borders are DJ and ileocecal valve. Okay, so there's no root lateral to either one of them. Our parietal peritoneum, if this delineates the parietal peritoneum, it's just a big balloon, right? It's just a big, big sac with serous fluid in it. So it's like a water balloon. And so the water balloon thickens up back here at the parietal, at the root, the superior aspect of the root, and then it comes around and it thickens up at the inferior aspect of the root. And then inside this balloon is like your stomach and your liver, and your small intestines are in there, and there's a bunch of serous fluid in there. But it's really this parietal peritoneum that will eventually get pulled lateral and posterior and pull those rectus abdominis bellies with it. Okay, so what we're going to do is we're going to treat the root first. Okay, so we're going to treat the root first. So this is the root, and here's how we're going to treat it. We're going to come in and we are going to take our thumbs just from DJ to ileocecal valve. We're going to sink down into the body, and then we're going to slide down till we hit the root. It's feels like a little bit of a speed bump. Okay, once I hit it, I'm going to load perpendicular and scoop anterior, and then I'm going to move my thumbs over and test again. I'm going to test this entire superior aspect of the root till I find the tightest spot. When I find the tightest spot, I'm going to stay on it. My fingers are going to reach across the belly button, but not lateral to DJ. And my one finger from each hand is going to sink in and slide up until I hit that speed bump, that root of the jejunal ilium on the inferior aspect. Once I hit it, I'm going to load it perpendicular and scoop anterior, and then move my fingers over towards ileocecal valve, meaning to the right of her body, and I'll test another spot, and then another spot. So I'll test numerous spots. Whatever's the tightest spot there, I'll leave my fingers there. Once I'm on the tight spot on the superior aspect of the root and the tight spot on the inferior aspect of the root, With visceral manipulation, it's really kind of fun. Whatever the test is, that's the treatment. So my thumbs are going to sink in, load perpendicular to the root, scoop anterior, and then I'm going to ask her to like move her arm up until I feel tension under my thumbs. Once I feel tension, I keep my load, and I'll feel a release where the root is shearing back and forth and creating a release of its own. So the body is actually creating the release. When the release is done, my thumbs stop moving, she brings her arms back down, and we relax and we test it, and it should be looser than it was before. We're going to do that 3 times for the superior aspect of the root. Then we're going to come down to the tight spot on the inferior aspect of the root. We're going to sink in, load perpendicular, scoop anterior, and then I want to take that balloon, that parietal peritoneum, away from my fingers. And the way I'm going to do that is have her do either an anterior pelvic tilt, posterior pelvic tilt, or maybe some hip rotation left or right to create tension under my fingers. Once the tension is under my fingers, her body's not going to like that tension. Her root is going to start to release, and it'll feel like a shearing back and forth. We'll treat that about 3 times. At the tail end of that, our thumb and our fingers are going to sink down, load perpendicular, and scoop anterior, almost like we're picking the entire root up, and the release will feel like my fingers go one way and my thumbs go the other way, and it's a really fast release, and then it'll be done pretty quick. Okay, so that's kind of where we're headed. Go ahead and bend your knees for me. Okay. And then this is an anterior pelvic tilt. Yep, that's a posterior pelvic tilt. Good. And then bringing your knees to the left very slowly, bringing your knees to the right very slowly, about that speed. Okay, good. So here we go. We're going to start superior aspect of the root. So I find DJ. Okay, so I know DJ is on a line from her left mid clavicle down to her umbilicus. So it's about right here. Okay, so I'm going to go superior to that, maybe a little medial with my thumbs. My sides of my thumbs are going to sink in, and then they're going to slide down. There's her root right there. She probably feels it. There's some tension there. And I'm going to load it perpendicular to the root and scoop anterior. Okay, and I'm assessing how tight is that spot. Then I move my right thumb over and then my left thumb over. I do it again. I sink in, I load perpendicular, I scoop anterior. Is that spot tighter than the first one is all I'm asking myself, and for me the answer is no. And now I'm going to move my right thumb over, my left thumb over, and test again. Not so bad. And we keep moving over until we get over to about ileocecal valve, which is about right here. And there's no problem. The more we get over to the right side of her body, the looser the root gets. And so it's not too big of a deal. Close to DJ though, that's tight. She just smiled, so she can feel that. So that's my tight spot. I'm going to leave my thumbs there. My fingers, right, are going inferior to the belly button, but not past DJ, meaning not to the left of DJ. Okay? And so my fingers are going to sink in until I feel some tension. It's about right there on her. I'm going to slide them up towards me until I hit the root, which is right there. That's the root. Okay, once I hit the root, I'm going to load it perpendicular and scoop it anterior, almost like I'm plucking it towards the ceiling. How tight is that? Move my right finger over, my left finger over. I'm going to do it again. That is really tight. Right? And I'm going to do it again. Right finger over, left finger over. That's not too great either. So she's got a lot of tension in the inferior aspect of her root. So I just keep testing all the way over to about ileocecal valve. Again, as I get over to the right side of her body, it gets looser. But right there, that's it. She just smiled. That's it. Okay, so these are my tight spots. So my thumbs are on the tight spot on the superior one. It's a little bit to the left of the belly button. And then my fingers on the tight spot on the inferior aspect of the root. And it's pretty much straight inferior to the umbilicus. So we're going to treat each one of them. So the thumbs are going to sink in. Load perpendicular to the root, scoop anterior. Go ahead and bend your right arm for me. There you go. And then just lift it up very gently over your head. So, yep, clear me. So, slower. Come back down. Come back down. Super slow. Just keep going. I'll tell you when to stop. Keep going. Right there. Stop right there. Okay. So, I stopped her the moment I felt tension under my thumbs. And now what's happening is the release. The root is shearing to the left, and now it's shearing to the right, shearing to the left, shearing to the right, and right there, stop. Go ahead and bring your arm down, but keep it bent for me. Okay, and then I retest this spot. Is it looser than it was a second ago? And it is. It's better. All right, we're going to treat it again. So we sink in, load perpendicular, scoop anterior. Go ahead and bring that arm up. Keep going. Keep going. Right there, hang there. Okay, and again, the root shearing left, root shearing right, like up to DJ. Now down the ileocecal valve, DJ, ileocecal valve, and there it stopped. Bring your arm back down. Good. And I retest. Much better. The root sits just anterior to the abdominal aorta. I'm starting to get a really strong pulse on her, which is a good sign. Something's just releasing for her. So I'm going to do this one more time. I load perpendicular, I scoop anterior, bring that right arm up just because that's working for us. Right there, hang right there. Now I could have had her move her neck, like if she came in with neck pain. I could have had her do some breathing. Anything that would take the parietal peritoneum up and away from where I'm loading. Good, and then come on back down. Good, and you can totally relax that now. Yep, good. So again, if I retest that, much better than it was a second ago. Okay. So then we come down to the inferior aspect of the root. I just want to make sure I'm being very specific on this. This is a bigger deal for her body from what I can feel here. This is really tight. This is it. So my fingers are going to sink in, load perpendicular to the root, scoop anterior, and I'm going to have her do an anterior pelvic tilt for me. Go ahead and do that. Yeah, perfect, good. And then keep that and take your knees to the left just a little bit. Right there, stop right there. So the moment I feel tension, I tell her to stop. And now the root is shearing to her left, and now it's shearing to the right, shearing to the left. This is her release, shearing to the right. This is how it's trying to release whatever restriction is here. Kind of back and forth, left and right. And there it stopped. Go ahead and relax. Go ahead and relax everything. Good. Good. And then we retest. A little bit looser than it was. Okay. And we're going to do it again. So I'm sink in, load perpendicular to the root, scoop anterior. Go ahead and do that anterior pelvic tilt. Yeah, great. And then take your knees to the left again. Right there. Hang right there. And the root is shearing to the left, shearing to the right, shearing to the left, shearing to the right. Right there, just stop. Go ahead and relax everything. You're doing great. Yeah, good. Starting to let go. And we do it again. Perpendicular, scoop anterior, anterior pelvic tilt again. Go ahead. Yep, yep. Take your knees to the right. I'm just curious. Nope. Not back. Down to the left. Right there. That's good. So again, creating tension under my fingers. And then the shearing happens. Kind of left, right. Just back and forth with the root. And then eventually it's done. Like go ahead and come on back. Good. And then retest. Much better. So now we have the restriction was up here on the superior aspect, the restriction on the inferior aspect of this root. We take our thumbs and fingers and we sink down, and then we bring, it's almost like bringing both of the aspects of the root together. There's a little opening in between them. And then we pick it up just a little bit off the back wall. The release feels like my thumbs are going to the right and my fingers are going left, and now it just switched. My fingers are going to the right and my thumbs are going to the left. And it switched again. Thumbs are going right, fingers going left, and there it's done. That one's really pretty quick. It's kind of a little bit of a finisher. So that's the root part of the jejunal-ileum. Okay. Now for the mesentery, or from loops to loops, we're going to do loop to loop next. With the loops, sometimes we don't know why this stuff happens. You know, maybe with pregnancy, these loops kind of get squished together, right? And then they get stuck. Maybe there's been a car accident. Maybe she's been hit. You know, who knows? She's some force to the abdomen. But sometimes they get stuck together, okay? So like if these two are stuck together like this, these are the loops, right? We want to release that, okay? So one thing that we're going to do is we're going to check motility. Motility is an embryological migratory pattern of every organ in the body. And for the jejunal-ileum, the movement is kind of like if I was opening up an Asian fan to up to the left and anterior, and then it would close down and posterior, okay? What I'm looking for, though, is do I have a space under my hands where I feel no movement? So if these two loops were stuck to each other and my hands were here, I would feel movement here, 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 and then it would skip this spot. And then I'd feel movement here, 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 and then when the fan would close back down, movement, 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 no movement under these hands. Okay, once I don't feel any movement under these hands, or under this hand, under these fingers, I'm going to put 2 fingers on that loop that's stuck to this one. And so if I push the loop down towards the table, the loop that it's stuck to is going to come with it, which means when I let go, I drift off, the loop that is stuck to it is going to pull it. Okay? When that happens, I'll feel a drift. When I feel a drift, I'm going to put my other 2 fingers right on that loop, and I'll sink down into the table until I feel like I have to push. I'll drift off, and there's going to be movement. Okay, the loops are going to move and create their own release. When the movement's done, I remove my left finger pads. I'm still on the original loop I got pulled to, and I retest. I sink down and I drift off. If it pops straight up to the ceiling, I'm done. The release is finished. If it still gets pulled over to the left, I put my fingers right where I get pulled to, and I do it again. And there'll be some type of twisty, turny, usually it's a clockwise, counterclockwise motion. But again, once it's done, the loop will just pop straight up to the ceiling. And then I'll put my hand down and make sure that that fan, that motility, is going through that spot. Okay, so that's kind of where we're headed now. Do me a favor, bend your, or actually keep your knees straight for right now. When we go to treat, we're going to bend the knees. So motility, we take up as much real estate as possible. The jejunal ilium takes up a lot of space. Go over close. And so here we go. So the fan is kind of closing in and down to the right. And now it's kind of opening up and going to the left. So now what I'm going to do is I'm going to focus on where do I feel a lot of movement. And then I'm just going to remove that hand. Yeah, I feel a lot over here. So I'm going to focus on my right hand. I feel a lot over here in my pinky and my ring finger. So now I'm focusing on these. I feel a lot up here in my thumb. I feel a little bit at my index. It's literally right underneath my middle finger. I just don't feel anything moving there. So with that, I'm going to put my fingers right where I felt no movement. Go ahead and bend your knees for me. Anytime I have to sink in the body, they're going to bend their knees. So these 2 fingers are going to sink straight down towards the table. So I'm taking that loop straight down. There we go. And then I'm going to drift off and see, do I feel an attraction? Almost like if this was the center of the sun and there's, you know, the sun rays, right? That's where my attraction is going to be. It's going to be right next door. Oh, yeah. Okay. So I'm getting pulled right here. Right? So then I put 2 fingers from my left hand there. This is the neighboring loop that is upset. So I bring both of them straight down towards the table, and then I drift off enough so they can move, and here they go. One is doing a clockwise motion while the other is doing a counterclockwise motion. This is her release. And now they're doing the opposite. So the right is going clockwise while the left is going counterclockwise. And now they're coming back in again. So the right is doing counterclockwise while the left is doing clockwise. And right there they stop. Now they didn't drift away from each other, so I'm assuming this is not done yet. So this is my original spot here. I'm going to sink down on that loop, and as I drift, sure enough, it's still upset with this same loop here. So we're going to do it again. So I felt an attraction. I felt a drift going this way. So here we go. We're going to sink in, and then we drift off just enough so they can move. If you drift off too much, there's no proprioceptive input and there's no mechanoreceptors being stimulated, and you won't get a release. They're still doing their counterclockwise and clockwise motion. My pressure is only to the table to engage them. Now, we got a little bit of moving away from each other. So the loop under my left hand is starting to move up towards her belly button and kind of to the right of her body, while my loop in the right hand is moving down towards her pubic bone. So I'm going to remove my left hand, give it a break for a second, and then I'm going to retest the original loop. So I sink in, I come up, Sure enough, that was it. Okay, that's all it needed. The loops moved away from each other, and now this loop is just popping straight up towards the ceiling. So then I put my motility hand down just to make sure, if you think of that fan moving through there like this, do I have movement under there? And I do. Okay, and that's all I care about with the loops. So that's the second part of the jejunum-ilium. The third part, and the last part, is the mesentery. This is a little big for her, but if we think of the root being above and below the belly button, right? Again, that's thickened parietal peritoneum, this maroon thickened parietal peritoneum, and then the parietal peritoneum continues on as the mesentery. The mesentery is like a sling, and it wraps around 21 feet of small intestine, and then it comes back and attaches to the inferior aspect of the root. Okay, so from the superior, it comes across, it wraps around, and then it attaches to the inferior. And so inside this, okay, we have some mesenteric arteries and veins, okay, and there's some nerves in there as well, right? So this is really, really important because the root is anterior to the abdominal aorta, because the abdominal aorta is retroperitoneal. It's behind the balloon. If we don't have a space between these two aspects of the root, and this was together and clamped off, 21 feet of small intestine would die. There's no arteries and veins. None of the blood flow could get to or from the small intestines. Okay, so this is really, really important. So think of this as like a sling or an apron, this mesentery, that's kind of protecting this vasculature. What can happen is if there's a restriction, meaning there's some scar tissue or something that creates like a little knot in this, that's what we're going to be feeling, is where is that restriction at? Okay, and so the way we're going to treat this is this. So we have our inferior aspect of the root there, and then we have like the mesentery coming off of it. Again, here's our vasculature, and then here is the superior aspect of the root. We have the mesentery coming off here. So again, there's a little opening here. All the blood flow is coming out for that, going through the 21 feet of small intestine. So the way we're going to treat this is this. We're going to get on the most restricted spot on the inferior aspect of the root. So for her, it's below the belly button. I already know that. I'm going to leave one finger on that. And I'm going to sink in, load perpendicular, scoop anterior, just like I did the root. And what will happen is, if, let's say this is the restricted spot, okay, so maybe there's a knot here, there's a little restriction. What that means is when I engage the root, this part of the mesentery is going to move first before the rest of this mesentery, because the rest of the mesentery is longer. This has become a shortened piece, which means the loop that this piece wraps around is going to move first. Okay, so a lot of times what I'll do is I'll sink in, load perpendicular, scoop anterior, and then with my right hand, I'll try to figure out where do I feel a connection, like right here, connected, connected, connected to my left hand. Okay, if I come over here, I'm not connected. I'm not on the same tissue. And then eventually I fall off, and then I come back on. So I'm at the end of the connection right here. When that happens, my left hand, my left finger sinks in, loads perpendicular, scoops anterior, while my right finger pads sink posterior on a loop, and then they pop up a little bit so the loop can move. The release typically feels like the root moves back and forth between DJ and ileocecal valve, and it feels like the loop usually does some rotation or some gliding or something like that. Okay, we'll do this a couple times until the loop moves away from the root, meaning this lengthens. That's what we're looking for. Okay, so looks like this. Go ahead and bend your knees for me. Okay, so let's just find this tight spot on her inferior aspect of the root, so that's below the belly button. I kind of know where it's at, but I just want to retest because we've been treating. It may have changed a little bit. Yeah, all of this is okay. So it's still the same spot. Okay, so right below the belly button, just a little bit to the right of it. This is it. Okay, so with my left hand, I keep one finger right on that. Okay, and then as I do that, I load perpendicular to the root, scoop anterior, and you can kind of see we've got a line. Okay, so I'm going to follow that line down, and with this right hand, I'm going to be like, ooh, super connected. Okay, if I come over here, I'm not connected. If I come over here, I'm not connected. Very connected. connected, connected. I'm kind of falling off here, falling off. So now I need to come back. And she's got another like scar here that I didn't know about. And so this happens a lot, you know, with these suprapubic scars. When the body heals, sometimes a loop or the mesentery of the jejunal ileum kind of gets wrapped up in this. So that's what I think is happening here for her. And this is a strong connection. So I'm right on her scar, which means the loop is right underneath here. Okay, so I'm on the root up here with my left middle finger. I'm on the loop down here with my right middle finger. And here we go. My left hand is going to sink in, load perpendicular, scoop anterior. It's only one finger that's doing it. Okay, we're being very specific. My right hand, I'm going to sink down towards the table and drift off of this loop so it can move. And here we go. The root is kind of shearing towards the ileocecal valve, meaning to her right. The loop is shearing towards her left hip, and it's doing a counterclockwise motion. Okay, just switch. So now the loop is doing a clockwise motion, and the root is going up to DJ, meaning towards her left. And there she just stopped. Now the loop didn't move away from the root, so I don't think we're done yet. Okay, so I give it a break, give it a second or two, but I keep my spot. And same thing. Again, I'm going to rest these fingers, but they're not doing anything. It's just my middle finger that's doing stuff. Left middle finger sinks into the inferior aspect of the root, loads perpendicular, scoops anterior. Right finger pads, sinks down to the loop, drifts off just a little bit, and here we go. The loop is doing a counterclockwise motion. I am visualizing the mesentery. I'm working in between my hands. Okay, I'm working in between my hands. The loop is now going clockwise, and the root is going to ileocecal valve. My pressure is still loading perpendicular, scooping anterior with my left hand, and just a little posterior pressure on the loop with my right. And right there, she stopped, but they didn't move away. So I don't think we're done yet. So I give it a break, second or two, and we do it again. Left middle finger sinks in, loads perpendicular, scoops anterior. Right finger sinks posterior on the loop, drifts off just enough so it can move. Here we go. Now things are changing. So the loop is shearing towards me, towards her right. And now I'm very happy to say it's going inferior a little bit. So right and inferior. The root's kind of not doing anything right now. And that can happen. Yeah, there we go. And I feel like the loop just kind of moved towards her pubic bone. Okay? So I feel like there was like an opening, a space that happened here. So again, if that mesentery was kind of, the visual I use is like a knot was in it, and then we untied the knot and the mesentery lengthened, so the loop moved away from the root. That just happened. That tells me I've given this enough to work with. Now, we've treated most of the jejunal ileum right now. We treated the root. We did loop the loop. We treated the mesentery. The last thing we do is motility. We go back to that motility, embryological migratory pattern. This is super light, but very, very important. Okay. And I'm going to encourage this into ease. So again, think of the Asian fan kind of opening up to the left and anterior, and then kind of closing down into the right. She kind of likes closing down to the right, so I'm going to encourage it in that direction. It's going to kind of look like paint drying. You're not going to be able to really see much, so it's going to be a little boring on this video camera. But while I'm doing this, I'm going to explain a little bit about visceral manipulation. It takes about 3 weeks, give or take, for a visceral manipulation treatment to play out, meaning we make a change in the body. We start a communication with the proprioceptors and mechanoreceptors. We actually have PET scans of the brain that show different parts of the brain lighting up after we do our treatments. And so when patients leave our treatment room, the treatment's not done. So for the next 3 weeks, their body's going to be working on what we just did. So we'll see if her DRA has changed here under this treatment or not. Hopefully it has, and most of the time it has during treatment. But it will continue to change for the next 2 to 3 weeks. And then we'll see them again. And again, some of our patients we see once a week, and some we see once every 3 weeks. It just kind of depends on our analysis of what's going on with them and everything we need to do. But with visceral work, we're not here to fix something right in the middle of a treatment. We're here to start a communication and then allow the body to do its own healing. Right? All right, so this is starting to feel a little better to me. What I'm wanting is that fan to kind of open up and to the left in the same fashion as it's coming down and closing to the right, meaning it's like this and they're matching. So it's a little bit better. So we're going to come back and we're going to retest our DRA. And so again, you'll notice I'm doing the same thing. So my right ring finger's in the superior aspect of her belly button, right where my index finger comes, that's where I want to be. So I can already feel a little bit of a change here with me just trying to sink. It just feels pretty superficial. Go ahead and lift your head up for me. Nice. Okay. So that right there, that's her belly right there, muscle belly, okay? So I went from 3.5 finger widths to 2. This is their muscle belly here. This is her muscle belly here. So edge, edge, okay? And so superficial. Like, go ahead and come back down. So 3.5 to 2, and her depth before was maybe like this. Now it's like this, okay? So it's really, really, really shallow. I'm going to come down to her umbilicus, or her belly button. And I'm going to get that ready. Go ahead and lift up. Very good. Come up a little bit higher than that. Very good. Okay, so for this one, I would give this a 2 as well. Okay, so here's her muscle belly popping up there. And then here's her muscle belly popping up right there. And again, it is very, very shallow, which is great. So again, 3.5 to 2, 3.5 to 2. And then you'll see my left index finger in the inferior aspect of her umbilicus. And then right where my ring finger comes, that's where we're going to measure this. I really feel like the mesentery was pulling this guy open, so we'll see what happens here. She still has a restriction in her mesentery. That's not completely done, so I'm not sure if this is going to change or not. Go ahead and lift up. Go ahead and lift up a little bit more. So for me, this is maybe a 2.5. Okay, so I can get part of my ring finger in there, but not my full finger. So she went from 3.5 to 2.5 here. Again, there's still something that needs to play out in that mesentery. So just to recap, 3.5 finger widths up here, down to 2. And then 3.5 finger widths to here, down to 2. And it's pretty shallow. This is more shallow than this is. And then this one, 3.5 finger widths to 2.5. And again, she needs to be treated again probably 3 more times. So again, about 4 visits of this. And what we're finding is it's closing up, and then it's stabilizing and it's staying closed, which is a fabulous and wonderful thing. And then they can go ahead and strengthen. And that's our treatment of DRAs.